Hey everyone, welcome to the podcast today. So I'm doing a little more teaching in what we call functional vision screening. So the difference between functional vision, which is dynamic, and static vision, which is eyesight, is huge. And when we start talking about how to use these two eyes in relationship to the brain and body, we can do a number of tests that can help us determine what's the best course of action in being able to help a person improve their vision. So again, I'm going to invite you in and part of the lecture today that we did with our class. I think you'll find it to be very interesting. Again, if you have any questions, you can send me an email, appointments@drsamberne.com. Enjoy the show, everyone. So this is called assessing functional vision. And this is an assessment that I have developed over the years, and I've given it to many occupational therapists, physical therapists, teachers, people like yourself. And so I will give you a worksheet that you can use to actually take the notes when you actually do the testing. But for today, we're just going to start in on the ideas of it. So here we have a person who's on a Bose ball, and we're working with the inner ear, the vestibular system, which is very tied into vision. And I'll talk more about that in a few minutes. What I did here is I made a list of things that relate to each other. Like, for example, if you have a child who tilts their head, they usually have what we call astigmatism, which means that the eye is shaped more like an egg instead of being round like a ball. And astigmatism is influenced by our posture, head posture, neck posture. So there's that relationship, head tilt, astigmatism. Now, double vision, meaning I see two of something, that could be related to something called stimming, coordination problems. So that could either be body coordination problems or visual coordination. So it could either be gross motor or fine motor or both. A lot of times there is a gross motor coordination problem, and it can even relate to some of the primitive reflexes that aren't integrated. And we'll save the primitive reflexes for another lecture. But you can ask your client, do you ever see two of things? And a lot of times they'll say, yeah, I do. And the parents are like, I never heard that. So if you don't ask the question, then the child just thinks double vision is normal. Another behavior that you might see in the double vision is they like to cover or close an eye, especially when they read. Or you can look at their eyes and their eyelids, and the eyelid droops. It gets heavy. Another thing you can notice is that the pupils, which is the control of the light, it's the black circle, is always dilated. And if you see a child that's always got dilated pupils, they're under a lot of stress. There's a big stress response in their system. So in general, head position and posture, one of the things that I like to do is really observe how the child is writing and reading. Watch the child while he or she is hopping, skipping, or galloping. In one clinic that I work in, we actually observe the child walking on either a 2x4 or a piece of tape that was like a masking tape that we put along the floor, and they have to walk on that forwards and backwards. And we observe the arms, the hands, the legs, the feet. And then there's an exercise called the duck walk, pigeon walk. And this is where you ask the child to turn their feet out like a duck and start walking. And with most of the kids that I've worked with, when they do the duck walk, or the pigeon walk is when the feet are turned in, like a pigeon, you will see the upper part of the body kind of turning in or turning out as a way to try to help the feet stay in the position you're asking them to stay on. You can also look at their arms and their hands while they're walking, and it's going to clue you in that they've got some kind of motor developmental delay, and many times it's related to, again, the primitive reflexes not being integrated. If they're in a therapy situation and I see this behavior on the pigeon walk or the duck walk, I'll do something called Saccadic guidance, meaning that I'll start asking them questions. Hey, Johnny, is there another way you can hold your arm or hold your hand? And so that they are in a discovery mode of going, oh, well, my hand was turned in. What if I turn my hand out? Just as an example. So Saccadic guidance is a technique where instead of saying, oh, you're doing it wrong, or correcting them, which really is a missed opportunity for them to become better at problem solving. Because that's this whole process is teaching them to be experts at problem solving. First with their body, coordination, and then thinking, and then eventually they can transfer that to school. So when you're doing the Saccadic guidance, you're skillfully asking them questions and guiding them to a place where they try something else, and they've got the confidence because they're not afraid that you're going to correct them. They're going to be in an open space of just, well, can I explore it a different way? And then when they come to the right answer, you go, well, what do you think of that? And they might go, yeah, that makes sense. So then you're validating their experience in solving the problem. And I see this a lot with parents where, especially the mom, she's always like trying to correct her son. And I have to say, okay, please be quiet, step back, because we don't want you to correct your son because he's going to get this complex where he's going to be afraid to try things. And so we teach the parents, ask questions to guide the child so that they have the discovery of the answer. Okay, another thing that you can look at while they're walking is their eye fixation. Are they walking with their eyes pointing downward, like at the ground, or upward, like at the sky, or off to the one side or the other? It's going to give you information perhaps on what side of the body they have a preference towards, and ultimately we want them to have a wider peripheral vision so that they can go down, they can look up, they can look to the side, but they also have a centering point. Because the next thing, and this is not talked about very much, it's called visual regard. And the definition of visual regard is, it refers to the act of using your vision to locate, focus on, and attend to an object in the environment. It is a foundational skill in motor planning. Okay, so I see where I need to go first, and then I move my body based on the decision where I'm looking. This is so important in sports, for example. Kicking a soccer ball, playing basketball, playing baseball, tennis, golf, any of these. When you look ahead and you know where you're looking, then you're planning your body to move through that. And there are exercises that you can do to improve motor planning using visual regard, because it's going to affect coordination. It's going to affect how the person is relating to themselves and objects out there. And it also visually guides the hands and body. We call this proprioception. I know where my arms and my legs are as I'm using my vision. This gets a little more interesting when we start putting them in gravity situations where they're jumping, say on a rebounder, while they're reading a heart chart, as an example, so that there is a visually guided movement and their body follows that particular movement. So visual regard is something not a lot of therapists talk about, but it's really, really important. So what are some functional examples of that eye-hand coordination or visual regard? Well, one is reaching for a cup. One of the questions I ask moms a lot is, does your child spill their milk? Do they spill their juice? And that tells me that their visual regard is not accurate. So they have difficulty judging location, guiding their hands towards an object because their eye is tracking it or not tracking it. Another place we'll see it is in reading. So skipping words, being able to follow letters, words on a page. And then finally playing sports, which I talked about, tracking a ball in motion, calculating its trajectory, and preparing to catch it involves visual regard. And when you get really good with visual regard, you're great at anticipating where the teammate is, where the ball is. And this is where the athletes really take off, when they start being able to plan ahead and they can almost tell where things are going to be before they get there. Kids, they bend over when they're bouncing the ball, especially if I'm adding a metronome. And they think by bending over, they can be faster with catching the ball and throwing the ball. And so we're always in this correcting mode of asking them the question, well, hey, Johnny, what would it be like bouncing the ball if you just stood up straight up? What would that be like? And then he goes, oh, wow, it's actually easier on my muscles. But it's the vision that's leading the body here. It's not the muscles leading the vision. It's vision leading the body. And in the physical therapy that you and I are talking about, I feel that the more we can get the vision into the body and the more we can get the body into the vision, that really solves the issue for the kids around their learning disabilities and their reading problems, because it's not just the eyeball experience. As one of my teachers used to say, a vision problem is more than in the eye, it's in the whole child. And going on to this next slide, when you look at the pupil, and when you come here, we're going to do some pupil testing. You have a pen light, and you shine the light towards the eye, and the pupil should actually get smaller when the light comes to the eye. With a lot of these kids, what happens is the pupil doesn't constrict. It stays really big, really dilated. And then there's the issue where one pupil is big with one eye, say the right eye, and the left eye, the pupil is small. And that's called anisocoria. And that could be a neurological problem. It could be a stress problem. It could be a trauma or toxicity issue. But the pupils are there to kind of show us what's happening on the nervous system level. And also, when a child is reading a book and starts to bring it close, the pupil should get smaller as the person brings the book closer to their face. Just as like when they move the book farther away, or at this point, it's probably the tablet, the pupils should get slightly larger. So we will do some testing in the area of having a pen light and being able to test the pupils so you can see the movement. Again, when it's light, when there's a lot of light, the pupil should get smaller. When there's dim light, the pupil should get bigger or more dilated. And one of the tests I'm going to teach you is something called the Hirschberg test. And this is a test where you have a pen light, and we're going to talk about the Harmon distance in a little bit. That's the distance that is about 12 to 14 inches from a person's face. And what you do is you shine the light towards the person's eyes, and you look at where the pupils, the light is reflecting off the pupils. So it's a way for you to see alignment. So you probably have worked with kids where when you look at them, one of their eyes might be wandering in. One of their eyes might be wandering out. One of their eyes might be going up. One of their eyes might be going down. So in this Hirschberg test, they're looking at the pen light, you're right in front of them, and you want to make sure they have alignment. If they have misalignment, two things could be going on. One is double vision, and two is suppression, meaning the brain is shutting off the eye to avoid double. So we have in this slide, the technical term, esotropia, is when the eye is crossing. Exotropia is mean one eye is looking outward, so you'll see the reflection of the light on the inside part of the pupil. And then you've got the hypertropia where one eye is up, and hypotropia where one eye is deviated down. So you can have a vertical split, you can have a horizontal split. I'm going to tell you this, most of these kids have one of these four issues: esotropia, exotropia, hypertropia, or hypotropia. And for you to know that before you start the pursuit eye movements, which is the smooth movement, this is being able to smoothly move your eyes from horizontal left to right or up and down. Pursuits is one of those visual tracking skills that's really important for reading. The other one is called saccade movements, and this is the jumping from one position to another, like focusing from near to far, focusing from the left side to the right side. So in your testing, you can test both the pursuits and the saccades, and one of the things you're looking for is the child able to move the eye muscles smoothly, or is there jerkiness in the movement, or are they having to move their head and or their body to move their eyes? I've done so many, kindergarten eye screenings where we test the saccades and the pursuits, and we go, wow, they've got to move their head to move the tiny eye muscles. So can you imagine trying to teach them how to read? It's going to be really stressful for them because they don't have accurate eye movements at this point. And then we talk about something called convergence. This is what you're working with right now with the Brock string. Basically, it's 3 beads on a string, and the first bead is at about 12 inches from your face, and the child is holding the string on the tip of their nose in the middle of the eye level, and we spread the beads out equally, 12 inches, 24 inches, 36 inches, and we have them look at each bead, and they should see an X at whatever bead they're looking at. This is a skill called convergence. Convergence is a very important skill at aiming the eyes, especially when you read. When you watch the child's eyes to see if both eyes are tracking the target, or you can actually start to see one of the eyes moving out, and you can ask them, is this a double vision? Do you see two? We call this near point of convergence, where how closely can you move the target where they're able to keep converging. And hopefully they're able to converge well within the range of where they're holding their books when they read. Because if the convergence breaks down right at their reading, then they're going to get the diagnosis convergence insufficiency. And then we've got divergence, which is more like the magic eye you're doing, like the jelly beans, where the eyes are looking parallel. And in this particular way, this is more of a distance type coordination pattern. So divergence is more distance and convergence is more near. And you want to be able to, again, watch the client's child's eyes as you're moving the target towards their nose and away from their nose. And you can start to see, okay, what is their convergence, divergence abilities? Build a house, you start by building the basement and you build the foundation. And the basement and the foundation would be the primitive reflexes. It would be working with their balance. It'd be working with their gross motor coordination. And you probably wouldn't want to introduce the convergence, divergence, or tracking exercises. That metaphor would be like the bedrooms upstairs. So absolutely, because they don't have the gross motor connections. They're in a developmental delay. So you couldn't really introduce the ocular motor exercises like this, divergence, convergence, until their primitive reflexes, their balance, their bilateral coordination skills are foundationally more solid. It's absolutely. That's why there's a certain sequence in when you introduce these certain activities. This is a mistake that most behavioral optometry and vision therapy practices make. I'm sorry to say this, but I see the mistakes. I'll have people come to see me and say, I've worked in vision therapy for 2 years and I have not seen any improvement. And within 4 to 6 sessions of working with me in this particular method, the child's reading, they're playing sports, their problem is solved. So one of the issues is that the vision therapy exercises, they start too high up in the motor development and the child is not ready. So they learn a splinter skill, they can cross their eyes or move their eyes, but they're not really working with, fixing the developmental delay, which started way back more in the pre-verbal period. So you are right in not introducing convergence, divergence until you think they can have some success at it. You need to stay more with the basic things, and actually you'll get a lot more benefits by doing that than trying to force them into doing some things before they're ready. So in the divergence, going back to that, there's something called, blur, break, and recovery. So when there's a target and you bring it in, you ask them and go, well, where do you see double? And hopefully they see it like 3 to 4 inches from their face. Some kids will say, oh, I see double at 12 inches or 14 inches. Well, that's a red flag right there because they're probably in double vision when they're reading or writing. So you need to note that. The other thing is the recovery of the double vision, because you want them to be able to recover from the double vision pretty quickly. And with a lot of kids, their recovery is very low. In other words, you have to push it way away from them or pull it way away from them before the 2 goes back to single. And what that tells you is they're depleted. They don't have enough in their energy reserves to be able to turn the 2 into single. And this is where then you can start doing some muscle testing, educational kinesiology, which will come later, and maybe testing the child where they need either a change in their diet or supplements. And again, in one of the clinics I work with, the occupational therapist does educational kinesiology to find out what are the targeted supplements that will give that child more energy so their recovery is better, their developmental growth is going to be faster because they have more energy on a cellular level to make the changes that we're asking them to make. Now, another thing we like to look at is something called near-far fixations. This would be like sitting at your desk, looking at the board, and being able to copy what you see at the board. Now, the way we simulate that is through a small printed heart chart, which is at 12 inches, and a large printed heart chart, which is, say, 3 to 6 feet away. And so the exercise is done where they look at one letter on the small printed chart up close, and then one letter at the distance chart, and they'd be able to go back and forth with it. When they get good at it, you can have them bounce a ball and do it. You can even do it with the eye patch. But this near-far fixation exercise is really great for getting them to improve their copying. Now, just as an aside, and I didn't write this in, one of the primitive reflexes that most affects the near-far fixation is the symmetrical tonic neck reflex. And we've done studies where kids have difficulty copying. So instead of doing the near-far fixation exercise, we do the symmetrical tonic neck reflex. And that reflex allows the brain to move more into the frontal part of the brain. And so the near-far fixations automatically get better without having to do any exercises in the near-far fixations. That's how potent the primitive reflexes are in being able to change the visual skills. And in this near-far fixation procedure, we're asking the child to shift their focus from the near chart to the far chart. And sometimes you can add a metronome, sometimes you can put them on one of those Boza balls or a trampoline, or so you can bring in a vestibular component to it while they have to jump their eyes back and forth. It's a form of what we call saccades. Saccades, remember we talked about eye movements that are jumping from one position to another. And as the child gets older, the saccadic movement is more important for them, especially sports, processing information faster, being able to, motor in the world faster, making decisions better. So that saccadic near-far fixation probably would be great for like a normal 12, 13, 14, 15-year-old. For the young ones like 5, 6, we probably wouldn't do a lot of near-far fixations except maybe the Marsden ball, which is the swinging ball, and they're just hitting it and they're tracking it. That would be a gentle way to start the near-far fixations. But once you get into the heart charts, that's where they're already in a language-based situation, and so they're ready for that. Okay, suppression. And I know you know about suppression because when you were here and you got tested, what suppression does is it tests the person to see whether or not either they've got, number one, double vision, because there's a misalignment of the eyes, or instead of double vision, the brain says, I'm just going to shut off the weaker eye. It's going to go dark. And then the right eye has to do all the work. So in the bottom of the slide is something that I know you're very aware of, and that is the red-green charts and the red-green glasses. For sure, because in the special needs world, if you go to a conventional doctor, they're just going to say, well, you've got this condition, live with it, and there's no help whatsoever. There's no understanding that the person has some level of neuroplasticity to learn. And, even in this suppression, if we go to the next slide, where you have the child wear the red-green glasses and just look around the room, just the awareness of then being able to see the different colors, the red, the green. This is a really great way to start. But what I'd like to do is just to put the red-green glasses on and just see what their response is. A number of kids will say, oh, I just see the red, or I just see the green. And that tells me right away that there's probably a very good deal of suppression. And as they progress, in fact, you could try this too, wear the red-green glasses while you're doing the Brock string. It's a very interesting thing when you are doing the Brock string and you've got a red string and a green string. What's more dominant? Does the green string shut off? Sometimes it's a way we do add-ons where we add like the red-green glasses to the exercise, and it kind of gives them more information on this binocular vision. Another way that you can do this, the red-greens, is by using heart charts with strips vertically, alternating red and green and red and green. And again, they're at that Harmon distance, which is about 12 to 14 inches, and you ask them to read across the row. And I know you've done that because we've done it with you. And it's a really great, I think even we did it with your kids. And so this is another great way, especially when they get into reading and language, can they have that alternating situation. And then we move to something called visual midline. I was working with this today with a client. And the purpose of this is to see if the child is actually balanced between their right eye and their left eye. Because in a lot of cases, if a child is right-handed, on a visual midline, if we think of that as our steering wheel, our GPS system, a lot of times the steering wheel will start sliding more towards the left eye, with meaning that the right eye is now coming over and it's now taking over where the left eye is. So it's pushing the left eye out of the way. So the way you do this is a screening where they can either visually track a target, and you bring it into their midline. You can have them touch it, and where they report now, that's going to tell you where their visual midline or visual midline shift is. Now there's a vertical right to left where you're standing on the right side of the child's peripheral vision and you hold the pencil or the pen oriented vertically and move the target slowly through the midline from the child's right side towards the left side and ask the child to say now when the target is in front of their nose. So a lot of times they will miscalculate. You'll see it as, oh my goodness, the pencil's way over on their left side, but they'll interpret it as, oh yeah, the pencil's in the middle of my face. Well, it's actually not. So the vertical right to left is good to do. The vertical left to right is good to do, where you stand on their left side and you move that vertical pencil from left to right to where they think it's in front of their nose. You can also do horizontal, vertical. So sometimes what we have found is that when a person is looking, their horizon line, so when you look out at the horizon, okay, a lot of times kids will think that the horizon is lower than it really is. This happens a lot like in Down syndrome. That's where I mostly see it. And when that happens, they're always, their visual spatial world is actually pushed downward. And so I'll give them a prism that lifts their vision up, and there have been life changes when they start to have that horizon line match where the true horizon is. And at a later session, we'll talk about prisms and those kinds of things. But for now, the midline, whether it's horizontal or vertical, is something that you could start to play around with. And their cognitive ability. And, you know, on the testing side of it, is you certainly could try it. And if you're not getting an accurate response, then you just say, this isn't the right test to do now. But with some of your kids, about something called the vestibular ocular reflex, VOR. And the VOR is a test to see how much is the vestibular system, meaning the inner ears, helping a person with their balance. So we've got two sensory systems that help us with balance, really three. We have the eyes for balance, we have the ears for balance, and we have the feet for balance. It's like a triangle. And what happens with most people is that if they have an undersensitivity of the vestibular system, meaning the ears are not helping the eyes in balancing, the subjective behaviors that you will see, the child may be clumsy, bumping into things. If there's an oversensitivity in the reflex, the child might get dizzy easily or report motion sickness. So an underacting vestibular system is bumping into things. An overreacting vestibular system is getting dizzy or seasickness. So in terms of testing the VOR, because that will give you an indicator on whether the ears and the eyes are balanced or one system is overworking the other. So you have the child sit in a comfortable, they're in a comfortable standing position, and you're in front of them. And what you do is you hold up a target vertically at midline in front of the child, and you instruct the child to focus both eyes on the target and slowly turn the head to one side so they're turning their head while they're tracking the target. And they go as far as they can with their head on one side and on the other side. And you have them do that a total of 10 times, 5 on each side. So you count 1, 1, 2, 2. all the time they're maintaining the focus on the target. And so you do this 5 on each side, and then you can also do it vertically, okay, up and down. Same thing, where they're moving their head up, moving their head down, five in each direction. So now, once you do that, what you're looking for is a movement called nystagmus. That's where the eyes oscillate back and forth. And if you see no oscillation, okay, no oscillation, or the oscillation is less than 5 seconds, then they have an underacting vestibular system. Okay? If that oscillation goes beyond 10 seconds, then they have an overacting vestibular system. So somewhere between the 5 and 10 seconds, that's a normal response. Like you should see a little bit of ocular nystagmus for 5 to 10 seconds. That's normal. So at that point, and in most cases, the vestibular system is underacting. So you need to do some vestibular stimulating things. We'll get into this in a later session, but it could be something as simple where you're having them swing, they're swinging, they're rolling. Sometimes we'll do jumping, like on a rebounder. Sometimes we'll roll them on a physio ball, so we get a big physio ball, and we'll roll them. We'll use a Boza ball, and they can either sit on it or stand on it. So in other words, what we start doing in the therapy is we bring in vestibular stimulating things while they have to do visual focusing things. So it teaches them to bring in the ears to the eyes with the feet. That's the proprioception. And it's a very important connection, especially when a child learns to read. Because in reading, when they're tracking, there is a little bit of vestibular connection. There is a little bit of proprioceptive connection. And it's also very tied in to the Moro reflex. So if somebody has not integrated the Moro reflex, a lot of times their VOR, the vestibular ocular reflex, will show a very underacting vestibular system. And this can be related to birth trauma. So either cesarean section, forceps, suction, or just, the cord is wrapped around the neck. There's some birth trauma that's happened that's triggered the Moro reflex, which they can't get out of, and this starts to shut down the vestibular system because they're getting overwhelmed in this fight or flight freeze response. It's a trauma response, so they have to start shutting down their sensory systems, and it's very easy for them to shut down their proprioceptive and their inner ears. And so then the visual is overworking, and this creates situations where then they might need some glasses, like they need a prescription, because their eyes get so fatigued from over focusing, so they might become farsighted, they may become nearsighted. So that's the kind of the progression of why kids start to need glasses, especially early on, or another reason why they start developing an eye turn, crossing in or crossing out. So again, the way I'm teaching this is you're noting these signals and symptoms and putting it together in the history, but you're trying to treat the cause and not the symptoms. And what eye doctors do is they want to fix the symptoms. Well, guess what? You fix the symptom and you drive the cause further in. This is why when you start doing the physical therapy and you treat the cause, the symptom goes away and it never comes back, but it also creates a better processing of information and learning, and it's just a very exciting transformation. So I'll have more to say about the VOR, but this is basically just getting your feet wet with it. And then the last thing I want to talk about today is something called the Harmon distance. So back in, I would say, the 1940s, 1950s, there was a a scientist. His name was Darrell Boyd Harmon, and he was working with some of the more well-respected developmental optometrists about posture and working distance. And Harmon did a series of studies, I believe at Ohio State, where they took a look at what is the optimal distance you should be holding your books, now your tablets, when you read, and what kind of angle should it be at. So how far away should it be from your face, and what's the angle? And what he found, and this diagram shows it, is that if you are propping up the reading material at about 22 degrees in a slant board, what that does is it creates a 90-degree angle in a way where the child or the adult has the optimum potential to learn and read better. And so this 22-degree incline, it could be just propping their tablet up on some books so that they're at a 22-degree angle approximately. What this does is this is going to take the stress off their posture and allow them to learn better. Now, there's a little picture up here, which is a picture of this arm. Okay, there's a fist, there's an arm, and it's like an L. And what Harmon proposed is you take that fist and you put it under the chin. And that measurement from the end of the knuckle to the elbow, which is now under the chin, is your specific Harmon distance measurement. So, for example, a 4-year-old has a Harmon distance that might be 10 inches because they have a smaller forearm. You could take a 22-year-old person, their Harmon distance is going to be farther away, and that's based on how long the knuckle to the elbow is. And it's placed under the chin, and then you kind of look at, okay, that's my Harmon distance. One of the problems that happens with kids, and you've probably observed this, is you give them something to read, and you watch where they habitually like to hold it. And when kids hold their reading material closer than the Harmon distance, you can bet there's going to be a vision problem. Now again, vision is tracking, focusing, visual coordination. It's the brain, eye-brain-body connection. It's not eyesight, it's vision. When they bring that in closer than the Harmon distance, that is a great screening device that's going to tell you right away, uh-oh, they have a vision problem, focusing problem, coordination problem. And so you want to instruct them to have that 22-degree angle and get into the Harmon distance. And this is something I tell every parent that they have to do this. Okay, now sometimes they might need some low plus learning lenses to help them stay at that Harmon distance. Or if they're wearing a distance prescription, we might have to reduce the prescription or increase the prescription to allow them to have the clarity that they need at the Harmon distance. But with all your clients, you should be talking to them about the importance of the Harmon distance. You could actually Google Harmon distance, Darrell Boyd Harmon, and you'd get a whole page of different things that Harmon did about as a pioneer to create this idea. And it's, even today, because we're talking, it's, almost 80 years, 90 years, it still really holds water, and I still see it. I still work with the Harmon distance today, and especially with electronics, phones, tablets, computers, the Harmon distance is more important than ever. Okay. So focusing closer than your Harmon distance, I guarantee you in 6 months you're going to become nearsighted because you're in a visually constricted spatial situation. And it's the worst thing that kids can do. They start pulling it in because they think, if I pull it in, I'm stressed, I can learn better, I can focus better. But what it's doing is it's tensing the eye muscles, and it creates that visual confinement, which creates myopia. And so, and then you got the kids that are farsighted, and they're pushing the world away. And, that's a whole other thing. So functional vision screening. You know, I wish more school nurses and different institutions included functional vision in their eyesight screenings, because most eyesight screenings only measure the optics of the eye at distance. And this is an uphill, battle, because very few professionals even think about vision, which is the brain. Okay, well, that's our show for today. I want to thank you so much for tuning in. Until next time, take care.